My name is Lindsay A. I'm a pharmacist with the University of Charleston School of Pharmacy.
Oh, Lindsay, it looks like you either are on mute or, let me see. I can't hear you anymore or see you. She may have lost service and dropped connection. Sorry.
A couple about the overdose rates. We'll also talk about the access to naloxone. So the University of Charleston has several grants to provide naloxone throughout the state to different organizations. So we'll go over that, as well as changes to the legislation that have occurred in the past couple of years that have allowed further access to naloxone. We'll also talk a little bit about sustainability. It is great that we've had all of these grant funds come in the state for naloxone, but what happens when we don't have those grant funds? So what do we do? I mean, we have been looking at that to figure out ways to sustain the same flow, or at least similar flow of naloxone into the state if we didn't have the same grant funds. And then I'll just touch on some naloxone updates, really focusing on some of the new products that are out there. We've had a couple of new products get approved within the past year, so just kind of touch on those and make sure everybody's up to date with those as well. So looking at West Virginia, in 2018, our rate of overdose deaths was 51.5. 2019, it increased to 52.8, and we've been #1 for years. We're very far above a lot of the other states. But when you look at 2020, our rate increased tremendously. So we went from 52.8 per 100,000 individuals to 81.4 per 100,000 individuals. And just to give you some perspective, I did list how many deaths that equates to in West Virginia, and you can see it's a significant increase in 2020. National rate is 28.3, again, just to give you some perspective of how high our overdose rates are here in West Virginia. And that was an increase of over 50%. So huge increase in overdose deaths. We're also seeing a huge increase in synthetic opioids like fentanyl being involved in a lot of these overdoses. Also seeing methamphetamine more often being involved in overdoses as well. So we're definitely seeing some pretty scary trends with our overdoses. But one of the big things is, as you see here, I'm sharing 2020 data. When we're looking at overdose rates and overdose death rates, that data is not current. So we really have to look at other ways to see that information. So if we can go to the next slide, I'll share with you one of the wonderful resources that we have here in West Virginia. This is the West Virginia Office of Drug Control Policy dashboard. If you've never been on this website, I'd highly suggest that you get on there and take a look. It's very interesting information, but it's really a way for us to see those overdose deaths, those suspected overdoses, kind of real time. Okay, so if you can go to the next slide, I'll just show you one of these to start. So this is 2021 fatal overdose data and pending cases. The chart on your left really goes over, in light blue, it's your deaths, and then in the dark blue it is the pending deaths, and that's by month. You can also see by county on your right. And so I think this is interesting to be able to look at each county to see how many overdoses occurred in each county, as well as what drugs were involved with those overdoses. So you can see that for any county. Now, of course, my screenshot here just includes one little chunk of those counties. But again, if you haven't been on this website, you can go in and look at your county specifically. I did include Kanawha and Monongalia County because I figured WVU probably have some people in Morgantown here. So you can see those counties that may be more kind of like your county. And then if we can go to the next slide as well. This is just one of the other tabs. Oh, back one more, I think. Yes, thank you. This is one of the other tabs that I think is, again, it's very interesting to look at. When we look at EMS runs, now the one thing that we also have to understand is that not everyone calls EMS when there's an overdose, unfortunately. We definitely know that. We also know that not everybody gets transported to the hospital. But you can see by year, you can see how many suspected overdoses there were when it comes to EMS, so the EMS calls that come in. So again, if you look at the bottom, 2018, 7,056, and we see a pretty huge increase between 2019 and 2020. So we went from 6636 to 8632 in suspected overdoses. And of course, in 2021, it was a little bit higher as well. And to date, actually not really up to date, but it's through the end of May. Suspected overdoses in 2022, 3,718. So if you look at the right, you have that little chart with all the lines on it. So with that, it shows you by year. So it gives you some comparison per year, how many overdoses, when you're looking at all the years together. And then you can see how many individuals were transported or refused care at the very bottom of the screen. So again, this is just really more interesting information, gives you a better picture of what's actually happening now in the state compared to looking at 2-year-old data to kind of determine what to do and how to proceed really to lower those deaths. Okay, if we can go to the next one. So now I really just want to touch on kind of the response. So we have a lot of things that we can do to help reduce overdose deaths. Funding has been coming into West Virginia to increase access to recovery resources. But one of the biggest areas that is helping individuals is increased access to naloxone. And that's really kind of where the University of Charleston comes in, because we do see those grants and we try to get that naloxone out to any of the organizations that need it. Which brings me to my next slide. So pharmacy access. This was a change to legislation that occurred in 2016. And this is really the start of the major changes that we see with our legislation. So with the increases in overdoses, we realized that there's a need to increase access to naloxone. And so the law was changed to allow for pharmacists to be able to dispense naloxone with or without a prescription. There was a standing order that was written by our state health officer at the time that also allowed for pharmacists to be able to bill insurance. So what that means is if somebody walks into a pharmacy and says, hey, I'd like to get some naloxone today, they would be able to get it without a prescription. And depending on what type of insurance they have, the pharmacy was able to bill that insurance, which makes that more affordable for that individual. So I did want to include all of the different pieces of legislation here so you can refer to them. So this is 16-46-3A, where it allows for pharmacists or pharmacy interns to be able to dispense without a prescription. Okay, next slide, please. Legal protections. So this is another big piece that has changed throughout. I see that there is a question about the standing order, and I will touch on that kind of here in a few moments. But the legal protections really protected those individuals that were able to carry naloxone, but also able to administer naloxone. And so there's a couple areas that were changed kind of throughout those years. As I said, 2016 is kind of where everything started. And in 2016, there was some additions for legal protections when it came to pharmacists, providers, and laypersons to be able to either dispense to an individual when it comes to providers, or when laypersons are administering naloxone to someone, it did protect them as well from any kind of liabilities that would occur. So those are still in place. Now, there have been a few things that have been added since then. One of those is that we added organizations. So we saw this huge need for increased access to naloxone in the community. A lot of individuals don't want to come into pharmacies. So even though that was in place to increase access, it wasn't all that effective because individuals either didn't want to come into the pharmacy, or sometimes, and unfortunately I'm a pharmacist, so this hurts me to say this, but a lot of times people would go into the pharmacy and they would be either refused, maybe the pharmacy didn't carry naloxone, or maybe the pharmacy intern or pharmacist wasn't aware that they could get it without a prescription. And I still hear that sometimes, that an individual will be told that they have to have a prescription for it, and that is not the case. So there's a lot of issues when it comes in, comes to walking into a pharmacy to access naloxone. The best thing we can do is get out into the community and provide that access without any barriers. And so that's kind of where these organizations came in. Understanding that we have a lot of prevention organizations and prevention groups within the state that are able to get into those communities and provide naloxone. So that was changed right before COVID hit. That was added so that those organizations were able to distribute as well. Because prior to that, it was providers, so individuals that were able to prescribe or dispense, so providers and pharmacists, and that was pretty much it. So when it came to getting into the community, unless they had a pharmacist or a provider with them, they were not actually able to distribute. And we wanted to allow for that. And that's where that law was changed. There are some protections in there for those groups to make sure that as long as they are distributing in good faith in order to potentially save a life, then they are covered. Also, did hear a lot from other states when it came to harm reduction calls about individuals that were being told that they couldn't carry naloxone if they were pulled over by a police officer. In some states, individuals were actually getting written tickets for having naloxone. So we wanted to ensure that nothing like that ever happened in this state. So we did actually add a statement into the law a couple years ago as well, basically just stating that anybody can carry naloxone with or without a prescription. And it also says individuals or organizations. So when those individuals from those organizations are getting the naloxone to do that outreach, that if they get stopped with that naloxone, that they're protected as well. Next slide, please. This is a piece of the standing order that is in place currently. So I know there was a question about the standing order, and yes, it is still in place. This one actually was changed in 2021 to allow for those governmental and non-governmental organizations. So basically any prevention group or other organizations that wanted to be able to distribute naloxone. This allows for them to be covered under that state standing order and really kind of protects them under the state in order to provide naloxone. This was huge. This was something that we've worked on for a long time. But this was a big change that allowed for a lot of those organizations to be able to distribute, not just being put in the legislation, but we really needed them to be covered by that standing order as well. So now that that's in place, we've fixed a lot of problems. And one of the issues was also with jails, because we wanted to make sure that when individuals left the jail, that they were able to leave with naloxone. And one of the biggest challenges with that was that there was not a provider on site that could do that in all cases. So this really made a huge difference for that distribution. Next slide, please. Okay, so now we're going to touch on the grant-funded naloxone that we have with the University of Charleston. Next slide. Okay, so we have a couple of grants. We don't have all of these currently, so some of these are older grants. We started with the State Targeted Response Grant, or the STR grant, in 2019, I believe. And so we started with that grant, and the the PDO grant, or the Prescription Drug Overdose Grant, both of those started in 2019. And with the STR grant, we really were just trying to target harm reduction programs and other groups that we could know that we would be able to get naloxone out into those communities. At that point, we had not changed the legislation believe that changed in 2020. But at that point, when we started these grants, organizations were not actually included in that legislation. With the prescription drug overdose grant, we really focused on health departments. Again, just trying to get it into the communities where we could. And then with the SOAR grant, we really started looking at trying to get it out to any organization that had the potential to interact with individuals that were high risk. And high risk individuals have really been our biggest target, even though those individuals are not able to administer naloxone to themselves. They oftentimes can have it on their person in the event that they were to have an opioid overdose, or if a friend or family member experienced an overdose, that they would have it on them in order to help them as well. We also had the First Responder Comprehensive Addiction and Recovery Act grant, or the FR CARE grant. This focused mainly on first responders, specifically law enforcement. We also were able to utilize this grant for the quick response teams. I'm not sure if everybody knows what a quick response team is on here, but I will kind of touch on what that is here in just a few moments. And then we had the adult SUD block grant. This was something that was more recent. And again, this has the same focus as the SOAR grant. So really just trying to get into those organizations that have the potential to interact with high risk groups. Next slide, please. Okay, so this is a big list. We have, I believe, 187 addresses that we actually send naloxone to throughout the state, which is, to me, is pretty huge, because these are all of our groups. This is all of our, health departments. Really, everybody that you see listed on the screen are the individuals that we are distributing to. And corrections, as I said earlier, was one of the biggest challenges, but we now have 10 jails that are distributing naloxone when individuals leave the jail, so they're able to get quick education on how to use naloxone before they leave, and then they are provided with a free kit as they leave. We also have all of the juvenile centers as well have access to naloxone. And so this allows for juveniles that are high risk, or if they have family members at high risk, to be able to access that naloxone. Now, of course, we don't distribute to minors, or they don't distribute to minors without parental or guardian consent. But typically, as that individual is leaving that system, they're able to access naloxone, or at least offered that naloxone. With health departments, we don't have every single health department in the state that has naloxone on hand, but we do have the majority of them with naloxone. Some of the smaller health departments do not have the enough employees to be able to offer that quick training and distribution, along with all of their other duties, especially with COVID. So when COVID hit, all the health departments were slammed. It just made it really difficult for them, just manpower wise, to be able to distribute. So some of them don't have it at this point. We are working to get it in every single health department throughout the state, so that everyone in every county has access to naloxone. Community organizations, I've talked about that a good bit. We have a lot of prevention organizations that are distributing naloxone out into the community. And the big piece with this is that they can get places that nobody else can. So they're in the food banks, they're in the libraries, they're going out into doing community events. They're reaching out to high-risk groups by going out and trying to be in different areas that have higher numbers of overdoses. We have our ODCP, or the Office of Drug Control Policy coordinators, typically working through Prestera, I believe, but they're going out and they're doing outreach in their community. We have collegiate recovery in several of the universities throughout the state that are accessing naloxone and getting it onto campuses. So there's a lot of great community work being done by these organizations. So that was huge that we were able to add them. Our harm reduction program, so every harm reduction program in the state does have access to naloxone. We have the majority of our MAT or OBMAT facilities are able to distribute naloxone and have it on hand provide to individuals that are in their programs. Same thing with abstinence-based programs. We want to make sure that they have it as well. So if someone is leaving the program, that they're able to take a kit home with them. Same thing with our crisis stabilization units, or our CSUs. And then that brings me to law enforcement and first responders. We want to make sure that law enforcement has it on hand to be able to use. So it's a little bit of a different scenario than sending it to like a community organization. So when we typically send it to law enforcement, it's for them to carry, to have on hand in the event that they respond to an overdose. We also have some changes that are kind of in process right now for EMS. That will be not through the FR Care grant typically, but we do have some changes in place where we're hoping that EMS will be able to do leave behinds. We're still kind of working on the logistics of that. So if they respond to a non-fatal overdose or a fatal overdose, that they're able to provide naloxone as a leave behind. So they would provide the education and then leave naloxone with a family member or with that individual before they actually leave the home. Hospital access. So this is another area that we are working very diligently on, but there are challenges in a hospital setting for distribution or dispensing. So we're trying to work through those, but we do have several hospitals that are able to kind of get this worked into their emergency department at least, so that individuals that come in that are either high risk or have experienced an overdose or possible overdose are able to leave the ED with a naloxone kit. Not just a prescription. A lot of times prescriptions don't get filled. So we want to make sure that they leave with a kit in hand. Now the challenges come when we have a smaller hospital that doesn't have a dispensing pharmacy, makes it a little bit more complicated. And so those are the problems that we've been working through, but I think we're almost there for those hospitals. And then our quick response teams. So a quick response team is a group of individuals, usually includes a first responder and someone like a peer recovery coach or someone that works in recovery. And they will actually respond after an overdose occurs to see if they can help get that individual into recovery, usually within 24 to 72 hours after an overdose occurs. So they go out, they talk to the individual, the peer recovery coach or the peer recovery support specialist that is present will do their best to try to connect them to care if they're interested, and sometimes even transport them to care if needed. The really cool thing about quick response teams is that they do so much more than just that. And I didn't realize this until I started kind of working with a couple of them, doing some outreach events, things like that. We have quick response teams that are going out to where they know individuals are high risk. They're doing outreach into those areas, and they know where those areas are better than anybody because they're the ones that are going there after overdoses occur. So they're going out into these high risk areas and reaching out to individuals and trying to get naloxone out in those communities. So quick response teams have been huge, especially in counties where we don't have a lot of access. So in those counties with, the smaller health departments that aren't really able to distribute, or maybe transportation is a huge issue in those counties, these quick response teams are able to go out and kind of reach out into those communities. Okay, next slide, please. So sustainability, as I said earlier, grant funding is not going to be here forever, or at least to the extent that we have it currently. So how do we kind of manage what we're doing now? And we don't want to just hope it's always going to be there, right? We know it's not going to be there all the time. So we have to figure out ways that we can sustain the same flow of naloxone into our community, because we don't want to end up increasing our overdoses by not having enough naloxone access. So grant funding always is great. So, trying to look at other avenues for grant funding to be able to provide some of those kits. But we also need to think of ways that we can sustain this in different, without having grant funds. So things like prescription insurance. Right now with Medicaid, we have pretty good coverage. It's typically very inexpensive for someone to access that in the pharmacy. But we also need other ways for them to access. So commercial insurance sometimes is more expensive. So it could be upwards of $75 or $100 for someone to be able to access naloxone. So we need to work with those insurance companies in order to kind of lower that copayment for individuals to access it. We also need more access to low cost naloxone. So if that is over the counter, or if we can have other products that cost less, obviously, that would be better for individuals and would help kind of keep individuals from being deterred to purchase naloxone. Oftentimes, if somebody has commercial insurance or no insurance and they walk in to a pharmacy, for example, to access naloxone, it could be $100 for them to purchase. So a lot of times individuals just choose not to. Also, academic detailing. So this is huge for providers, making sure that providers are aware of the naloxone laws that are here in West Virginia, and really how to prescribe naloxone and why they should prescribe naloxone, and also in some cases why they could potentially dispense naloxone to individuals that are within their care. Same thing with continuing education. As I stated earlier, sometimes in the pharmacy, it's a little more complicated in some areas because individuals maybe in that pharmacy are not aware of our laws when it comes to naloxone, because they have changed so many times in the past few years. So providing that continuing education to make sure that providers and pharmacists are aware of those changes and really improve access within the pharmacies as well. One of the other pieces that I didn't put on here, but it's a meds to beds type of program. And that's one of the things that we're trying to work through with some of these hospitals that don't have that dispensing pharmacy, working with local pharmacies in order to provide that naloxone for those individuals before they leave. Because what we know is that a lot of times individuals will not fill a prescription. So you can hand them a prescription before they leave the hospital, but if they don't have that medication in hand, they may not fill it, especially if they don't feel that they actually need that product at that time. So we want to make sure that they have it in hand before they leave. Okay, next slide, please. Okay, so moving into naloxone updates, we do have a few new products. The one that you're probably familiar with is the 2 milligrams per 2 ml naloxone with the atomizer. This is one that is kind of put together. This is something that EMS typically uses. This has been around for a long period of time. It's been used, like I said, with EMS back when we started. Well, when I was working with harm reduction here locally in Charleston, this is actually something that we started distributing through some grant funds. But then we kind of moved into Narcan nasal spray, which is the second one listed here. And that's a 4 milligram per 0.1 ml. This is a nasal spray. Again, this is something that we use with the grants currently. So it is out there. A lot of people are very familiar with Narcan. But we do have two products that were approved within the past year. One of them is a generic nasal spray. So this is exactly like Narcan, but it is a generic formulation, and this was made by Teva, or Teva. So again, this is something that is out there. It's accessible in the pharmacies, and it is a lot less expensive than the nasal Narcan. So if someone comes in with a prescription or without a prescription and they want to purchase it, this may be a less expensive option for them. The next one is an 8 milligram per 0.1 ml. This is actually known as brand Cloxado. This is also a nasal spray. It is the same exact device as the nasal Narcan, so it looks exactly the same, directions are exactly the same. However, this one is double the dose, so it's a much, much higher dose. And so this is something that we will be purchasing soon with the grant. As of now, all we've purchased with our grant funds has been the nasal Narcan, but we will be adding Cloxado into that as well for organizations or groups that would like to have the higher dose. Moving into injectable, we do have our vial and syringe, which again, this has been used for years, typically through some of the harm reduction programs and sometimes street outreach, things like that. But we do have a new product that is an injectable, and this came out within the past year as well, and it's known as Zemi. And so this is a pre-filled injectable. It's in a pre-filled syringe, and it actually comes with a safety that kind of just pops right over the needle after it's used. So this is something that's out there. We have not purchased any of these with grant funds. However, it is a new product that is out there as well. Okay, next slide, please. Okay, so just really to summarize, we have seen a lot of overdoses have soared really within the past couple of years, especially in 2020. We saw that huge increase in deaths. Again, in 2021, we're still seeing some increases, although they are starting to decrease a little bit now. West Virginia has had a lot of changes to legislation to increase access to naloxone. So that is, as I stated earlier, adding dispensing by pharmacists without a prescription, adding organizations to distribution, and really substantially increasing the funding for naloxone and recovery resources as well. I don't have much to do with the recovery resources. I mostly deal with the naloxone. So we have seen a huge increase in funds. And with the grants that we've had, I mean, we've been able to send out tens of thousands of naloxone into the state. So it's been great. I think, at least I'm hoping, we're starting to make a dent and be able to get naloxone into the hands of people that need it. That's all I have. So I'm happy to take some questions if anyone has any.
Thank you so much, Dr. Ackery. We really appreciate it. And I know you're on vacay, so we super appreciate you taking time out of that to share your expertise with us. So thank you. But yeah, any questions, comments from the group? We can open it up. Feel free to unmute or chat in.
I had a question. Okay, the higher dose of naloxone, the 0.8, has it been a little more effective with people who suspect overdose with fentanyl or fentanyl? Or is it pretty much the same thing? You have like 20 minutes time before you get EMS there.
I'm having trouble hearing exactly what you said. Would you be able to type it in the chat?
Yeah, I put in the chat.
Yes. Okay. Thank you.
Thank you, Dr. Bo. Yeah, sorry, it was a little staticky sounding. But when you get that chatted in, we're happy to read that out loud for you.
There was a question, it was about the standing order, but asking if it was in effect since the standing order is no longer, or the health officer is no longer in West Virginia. We do have Dr. Amjad, who is our state health officer, and she has signed the new standing order. So she did sign a new standing order for pharmacies as well as the one for the organizations.
I guess this is David Bolt here. I asked that question. So if our state health officer was not in support of this, then it would be a problem, correct? It's not, I mean, there's laws that protect people, but it's all based on that standing order, correct? Or partly, I guess that's my question, because that's a political appointee.
Yeah, it's partly based on that standing order. So the standing order is really just to provide, just to really cover those organizations, to really kind of lay out how that distribution occurs. But we do have the legislation actually stating that those individuals can distribute. So they're still covered by the legislation as well. The standing order specifically kind of lays out what education those, or like somebody with that organization needs to have before they're able to distribute. So what kind of training they need and what kind of education they have to provide that individual before they actually distribute. So that kind of lays out the specifics. But if we didn't have support, it would just, they would still be covered, but it would just be a little bit more complicated.
Thank you for expanding on that question, Dr. Valtierra. And Dr. Bo, we got your question in the chat. Thank you so much for doing that. She was asking, the higher dose of naloxone, has it been more helpful for fentanyl overdose, or is it similar, kind of buys us just about 20 to 30 minutes?
So we're not, we really haven't used it much in West Virginia, so we don't really have that data. And there's really not any real-time data or real data of use out there to show that it's any more effective against the fentanyl. The idea behind it is that you're essentially increasing their concentration of naloxone quicker. So when you think about the peak amount of naloxone that would be in the system after, a 4 milligram dose versus an 8 milligram dose, you're going to reach that same peak that you would see in the 4 milligram a lot faster, because it's going to peak. The 8 milligram is supposed to peak a little bit quicker than the 4 milligram as well. So you're getting those higher concentrations of naloxone in the system quicker with that 8 milligram, but we just don't really have any data to show it's any more effective or anything like that. I think that's the idea behind it, but I don't know that is what we're seeing in reality in those individuals that are overdosing on these products. But we will see as we start to use it more in the community. We're trying to collect information, and that's one of the things that we're doing with this as well, is collecting that data to see if they are using it, how we see, is it working faster? Are we seeing a change in the amount of time it takes for someone to start breathing? So all those things we're kind of looking at when it comes to that real world data, because when they test it on, healthy people. So we just see those concentrations increase, but we don't really know what effect that has on the individual. Hopefully that makes sense.
Thank you so much. And Dr. Bo thanked you as well in the chat. Jordan, I saw you had unmuted. I don't want to put you on the spot if you didn't have a question, but I wanted to give you the opportunity.
So you actually just answered it. So it's not the 8 milligram dosing kind of applicability of it, but also just another comment. So we actually did a pretty big distribution here at Chestnut Ridge Hospital, Morgantown, about 250 our staff members, residents, and it's been used out in the community multiple times. So just it's kind of cool once you actually distribute it and notice make a difference and those kind of things too. So it definitely does make a huge difference. We from patients as well. So definitely very important. Thank you for the presentation.
Thank you for sharing that, Jordan. Any other questions or comments from the group? This is what we call the long echo pause in case some people do think of questions. Just wanted to shout out Dr. Houston hopping on with his flannel as well. And we have Derek with his floral t-shirt on. Just have to point it out.
Well, I will say if you all have any questions, you can reach out to me. I'll put my email in the chat. But you can reach out to me if you have additional questions, or if there is anyone on here that is with an organization that does not currently have access to naloxone, but would like access to naloxone to be able to distribute, or even just to have on hand, please definitely let me know, and I'll do my best to get it to you as soon as I can.
That's awesome. Thank you so much, Dr. Eckery. And we will be attaching your PowerPoint in the recap email we send out. So your information's on there as well. So we'll be sending out to the larger listserv. Some folks can't necessarily always join live, so it's a nice way to distribute materials that way. So I'll be sure to do that. And as always, if anyone has questions for me to relay as well, I know you put your email in there, so that's great, but you're welcome to email Elizabeth and I as well with any questions or comments. All righty, well, if there's nothing further, I will just go into announcements. Next session will be on July 25th, and Dr. Matthew Christensen will be presenting on MAT state laws pre-COVID versus COVID versus now, which sounds really interesting. So keep an eye out for that reminder. We'll try to reach out to the case presenter. Maybe we can reschedule for next time, because I know cases are really great for discussion and learning purposes. So we'll try to get that case to you all next time. And I hope you all have a wonderful evening. Thanks, everyone. Take care.